The pathophysiology of obstructive sleep apnea. It begins with a collapse of the upper airway during sleep, most often at the level of the oropharynx and the hypopharynx, which includes structures like the soft palate, the uvula, the tongue base, and the lateral pharyngeal walls. During sleep, especially in REM sleep, when muscle tone is at its lowest, the pharyngeal dilator muscles, particularly the tensor palatini and the genioglossus, relax. This loss of tone allows the soft tissue of the upper airway to collapse inward, especially if the patient has anatomical narrowing due to factors like obesity, large tonsils, or craniofacial abnormalities. Now, although the diaphragm and intercostal muscles continue to generate inspiratory effort, airflow is blocked due to the obstruction. This results in increased negative intrathoracic pressures as the lungs try to draw air in against a closed or partially collapsed airway. This negative pressure can actually worsen the collapse by drawing the airway walls even closer together, creating a cycle or a worsening obstruction. So as the airflow is reduced or completely stopped, we can see that PaO2 drops and carbon dioxide, so PaCO2, levels will rise. This triggers a chemoreceptor reflex in the brainstem and carotid bodies. Now, these receptors send signals that lead to a brief arousal from sleep. It activates the sympathetic nervous system to restore the airway tone and reopen the airway. However, these repeated arousals disrupt the normal architecture of sleep, leading to fragmented sleep, reduced time and restorative stages like deep sleep and REM, and excessive daytime sleepiness. So over time, when these patients have been in hypoxia for so long and the arousals, this will contribute to systemic inflammation, hypertension, insulin resistance, and increased cardiovascular risk. Now, the pathophysiology of central sleep apnea, in contrast to OSA, arises from not the physical obstruction, but from a failure of the central nervous system to generate respiratory effort. The brainstem, particularly the medulla oblongata, houses the central respiratory centers that normally respond to chemical changes in the blood, especially the rising levels in CO2. In CSA, these centers become unstable, which makes them fail to send the appropriate neural signals to the phrenic nerve, which activates the diaphragm for inspiration. Now, a major pathophysiological mechanism in CSA is instability of the feedback loop that regulates breathing. In healthy individuals, rising CO2 triggers deeper breathing, while lower CO2 reduces ventilation. In CSA, particularly in conditions like heart failure, this feedback system becomes overly sensitive and delayed. For example, if ventilation is slightly too aggressive, like often during sleep we experience this, CO2 may drop below the apnea threshold, which is a critical level below which the brain temporarily stops stimulating the respiratory muscles. This leads to a central apnea event where there is no chest or abdominal movement. The body simply forgets to breathe. Unlike OSA, the airway remains open during these pauses, but the ventilatory drive is absent. After a short period, rising CO2 levels once again trigger breathing, sometimes in a rapid, deep pattern called hyperapnea. which may overcorrect and again suppress the respiratory drive, creating a cycle of periodic breathing. And this can be seen in conditions like Cheyne-Stokes respiration, which is common in patients with heart failure. Now we have our mixed sleep apnea, our next one. I'm going to discuss the pathophysiology. It's also called MSA, or complex sleep apnea. It's a condition in which both obstructive and central apneas coexist, like we've talked about in the previous couple slides. The interaction is usually dynamic. So most patients initially present with typical obstructive sleep apnea, which the physical upper airway collapses, like we talked about. And once CPAP therapy is started to keep the airway open, some patients unexpectedly begin to exhibit central apneas, where airflow stops, but no effort to breathe is observed. This shift reveals an underlying dysfunction in the central respiratory control system that was previously masked by the more obvious airway obstruction. So the pathophysiology behind this is still being studied, but it's believed to involve instability in the body's response to CO2 and oxygen. So when the upper airway is opened with CPAP, ventilation improves and CO2 levels drop quickly. In some patients, this sudden drop can cause PaCO2 to fall behind or below the apnea threshold, which leads to a pause in central respiratory drive. Additionally, the patients with heart failure, chronic opioid use, or brainstem abnormalities may have reduced buffering capacity to regulate these fluctuations, which make them more vulnerable to ventilatory instability. Now, MSA involves both the upper airway structures, like OSA, and the brainstem respiratory centers, like CSA. The presence of both of these mechanisms make treatment way more complex. So CPAP may fix that mechanical obstruction, but it can unintentionally provoke or reveal central instability. This is why some patients with MSA require adaptive servoventilation or like other advanced therapies to maintain that stable breathing pattern. So the dual disruption in airway patency and the respiratory drive can result in persistent sleep fragmentation, poor CPAP tolerance, and continued daytime symptoms of the sleep apnea, even when the initial therapy seems appropriate.